You're watching Graded Exposure and Graded Exercise. Which, who, why, and how. I'm Nick Rainey, a fellow in training in Evidence in Motion's Orthopedic Manual Physical Therapy Fellowship Program. My interest in this subject has been piqued recently because I often hear physical therapists discuss using graded exposure in a manner inconsistent with how it was developed and what it truly is. Graded exposure is a classification-based treatment, not a last resort when other treatment has been ineffective. In this presentation, you'll learn a brief history of each and their definitions. We'll then focus on when and how to apply graded exposure with the patient. What is graded exposure? It's also known as in vivo exposure. So when you're reading the literature, studying this more fully, if you read that term in vivo exposure, it's the same thing. And its creation is credited to Joseph Wolpe. He's a South African psychiatrist after World War II. And he used a lot of research from Pavlov that was publishing around the same time on operant conditioning. And the key with graded exposure is that exposure level does not progress until fear levels have decreased. And it's a cognitive behavioral therapy. Graded exercise is also known as graded activity in the literature. Typically they'll use graded exercise. And this is the one that's been more extensively studied by physical therapists. And its creation is credited to work by Fordyce and also treatment that was for tuberculosis in the late 1800s. And here we establish a baseline and increase by predetermined quotas. So let's look back at graded exposure again. So this one, the exposure level does not progress until fear levels have decreased. So it's based on the patient's response. Where graded exercise, it's increased by a predetermined quota, regardless of how the patient is responding. Which one is better? Probably graded exposure, but as any good clinician will tell you, it depends. Graded exercise is more simple to apply, but I will try to make graded exposure as simple to apply in this presentation as possible. We're going to do it through a case report and then describe each of the aspects of this with this. Here we have a 56-year-old male with chronic back pain. Probably none of us has ever seen a patient like this. He was injured when he pulled a victim out of a wreck 4 years ago near his home. 15 minutes later, he felt a shooting pain in his back. The next day, he saw his general practitioner and who prescribed bed rest and NSAIDs. Still had pain, so he saw various other practitioners who provided exercise, modalities, wearing a corset, and even manual therapy. None were successful. He had nerve blocks. Those helped for about a month, but obviously he's still in pain. He eventually had to stop working as an accountant, and now he's sitting in your clinic. Something he says is, if I perform a lifting movement, my pain will increase, and if my pain worsens, the risk of damage to my spine increases. So this is something that if we did here, we all know to be on the alert that this isn't correct feelings about his pain. He says he always wanted to retire and have a small farm, but he knows that would require lifting and pulling. You then give him the pain catastrophizing scale. I like to give this as a screening tool initially, but if you haven't done that, this would be the time to do that. Here you can see the PCS. You can find it online. It's in Appendix B of the user manual that I have in the references below at the end of the presentation, or you can just type it up yourself. This is important to give to patients as a screening tool. It's pretty quick and it gives you a lot of good information. His score is a 42 out of 52. You perform the objective examination, and in conjunction with the subjective examination, you determine there are no red flags. There's no reason to believe that harm will come due to movement. That doesn't mean there won't be any pain, but harm will not happen to the patient because of movement. This doesn't mean that there are no impairments present. We can still treat impairments with other typical means that we treat those, but any type of movement is safe for this patient. And since the PCS is higher than 30, he's placed in a high catastrophization category or classification. And so we give this patient the Fear of Daily Activities Questionnaire, also known as the FDAC. You can see here on the left, the FDAC. There's 10 standard questions and then 2 more where they can write in. And they put a rating of 0 to 100, where 0 is no fear of activities, 100 is maximal fear of activity. Typical type of scale that we use with a lot of other things. I'm going to highlight 4 that he used that are important with this patient. Lifting 20 pounds or more were 100, so maximal fear. Pushing a wheelbarrow, same thing. Notice that one was a ride-in. Reaching to the floor is 70, and walking for longer than 30 minutes is 50. Here's the fear avoidance model, also known as the FAM. And this is done with the patient. You see the model printed in the middle, and then what you do with the patient is you write down the things next to thoughts, feelings, behaviors, and consequences. These are things that a lot of it we've hit already. Maybe some more comes out during this, but this way the patient can see how it all is working together. After doing the fear avoidance model, it's time for goal setting. As with any episode of care, appropriate goals are essential for a correct outcome. The key with goal setting for graded exposure is they must be functional. If the patient's only goal are pain reduction, then graded exposure may not be appropriate. Here's some appropriate examples of goals, not for this patient, but for any patient. The common things you may see is lifting a child, lifting a shopping bag, using a bicycle, walking to the supermarket alone, resuming swimming. The following are goals that are close, but are not appropriate. Returning to work, household chores, going on vacation. A theme that you can see with these is that they cannot be specifically tested. They're a little too general. They have to do with patient's life, but we cannot go test them specifically with certain activities. We need to be able to practice them. They need to be specific. When you have trouble with this, come back and look at this slide to help you elicit appropriate goals. The key here is to find out what functional gain would improve their life. These tips you'll find in pain-related fear, exposure-based treatment for chronic pain. That's where I take a lot of this presentation and where a lot of the other research is taken from the research that's illustrated in this book. And it helps with the nuances of it. They go over a lot of dialogue things, and these tips can help you get good goals, because without good goals, graded exposure will not be effective. For this patient, we choose pushing a wheelbarrow and lifting 20 pounds. We find these on the FDEC so that we can measure them, and they are relatable to his life. Before we conclude the session, after doing the goals, we need to do neuroscience education. This is an essential aspect of treatment that cannot be overlooked. One of Joe Nice's papers postulates that appropriate cognitive behavioral responses will follow when pain is appraised as less dangerous. The key is that we need to help them reframe, reconceptualize their pain experience, their condition. Common areas that we need to address are imaging, contradictions in diagnoses they've received from various people, sometimes healthcare providers, sometimes internet, sometimes friends, and that an absence of serious pathology does not mean their pain is imagined, purely in their mind or psychological. So what are some good ways to apply neuroscience education? Well, it should be integrated into evaluation and treatment through homework and with time directly dedicated to this. Every patient will be different. We need to make sure that we adapt our teaching to the learning strategies of our patients. The back book is a resource that is commonly used in the research and is a great resource. However, you probably don't have one of these in your clinic, which limits your ability to use this tomorrow. But it is pretty inexpensive, so I encourage you to take a look at it on Amazon or something. But I'm going to go over some other ones that are easily used as well. Greg Lehman has a couple ebooks on his site, or treatment workbooks and pain workbooks. The Pain Fundamentals one has 14 pages of educational text. The other pages are assignments that you can give the patient if you choose. Sometimes I do, sometimes I don't. The Treatment Fundamentals, same thing. There's educational text and things you can have the patient do. You can see the specific ones that I find are typically most beneficial there. Now, to conclude this first session, the patient is given the educational pages shown here. You may choose to give more or less, or give them videos, or the back book if you have that, but this patient is going to give these pages in the Pain Fundamentals and Treatment Fundamentals workbook. And then we also give them the Neurophysiology of Pain questionnaire. And the key is that this patient needs to fill it out after they do the reading and after the, so they'll have this first session with you and the reading, and we can measure how are they reconceptualizing their pain experience, their condition. And then we can start to address those misconceptions from there. Now we're at session 2. This session will set the pattern for what we'll be doing in future sessions. This is where we actually get to start applying graded exposure, the whole purpose of this presentation. First, though, we want to start by looking at the Neurophysiology of Pain questionnaire. First question to see is, did they fill it out? And then, how did they do with it? Are they starting to reconceptualize their pain and their condition? Did they do the reading? Did they glean from the reading? What are they saying to you? Did they brush through it right in the waiting room before you got them? Did they discuss it with somebody, think about it? Do they think it's significant for their life, or do they say they already knew it all? All these are good information, and this will dictate how much education you give here at the first, throughout treatment, what other type of resources you give them there at the end. Maybe they need videos, maybe they just need you to talk it out with them, answer a lot of questions. This is where it becomes very personal. Then we need to do the FDEC again for those items that we discussed earlier. Wheelbarrow pushing, lifting 20 pounds, walking, reaching to the floor. His didn't change at all. And remember, reaching to the floor was a 70. Walking was a 50. And the wheelbarrow pushing and lifting 20 pounds was 100. So we need to make sure, we want to be able to choose it right there in the middle. We want to go too high, don't want to go too low. That 65 to 80, maybe 60 to 80 range is ideal. We choose 1 or 2 to work on during that treatment session. For this presentation, I'll describe one of them. So here's the FDAC for that. He's still at a 70. He hasn't decreased since last time. And that's good to know. We put that fear activity, pre-activity fear level. And what's the clinic activity? We're going to put their hand on a chair, reach the floor with the opposite hand 20 times. That way they have a little bit of support. We're easing into that. 70 is pretty high fear. I don't want to go into that right away without testing out how they do with it. So at the end, they end up with 65 out of 100. It's improved from 70, not a whole lot, but we'll take it. So was fear reduced? Yes. And so the plan is to progress with no hand on the chair. Next time they come back, they're at a 70, so they haven't progressed overall, but we know how they responded last time with a somewhat easy treatment method. So we're going to increase it like we'd planned, touching the floor 20 times. Post-activity fear level is 70 again. Was fear reduced? No. So we keep the current volume. So this is the key of graded exposure. We don't progress unless their fear is reduced. That is a key to graded exposure training. So since fear was not reduced, we do not progress next time. We measure it again next time, and it's a 70. Even if it was lower, though, we wouldn't progress it from the time before. Since it's a 70, then we'll touch their floor 20 times again. Yes, this time it was progressed down to a 50. So we increase the volume next time. There's a lot of ways we can choose to increase it, but this time we'll choose to increase volume. Come back with a 55 out of 100, which is lower. We're going in the right direction, and we're going to stick with our plan to increase volume, 2 sets of 20. So now we're up to 40. We've doubled what we've done the last couple times. This time it drops to a 30, and their fear is reduced. Yes. The next time we'll increase the speed. You can increase volume. There's a lot of different ways that you could choose to increase it, but that's how we'll do it with that one. And you progressively do that. You can also do another activity in the same session. You could have chosen to do walking, maybe pushing a wheelbarrow. But this is the pattern that you'll use for those. And typically you can do 1 or 2 in a session, depending on the other things that you want to be doing that session as well. So I want to hit a few key points before concluding. The PCS should be given as a screen initially. We don't want to wait to give this after we've done a lot of other treatments. We need to know if they have high catastrophization behaviors. Remember, this is a classification-based treatment, not a last resort when other treatment has been ineffective. This means that if the patient is classified as having high catastrophizing behaviors, pain reduction isn't the primary goal, and is willing to focus on functional activities, then this treatment should be done. Remember, catastrophization is what is consistently reduced, not pain or disability. However, it may be that catastrophization reduction is a precursor to disability reduction. We just don't know in the literature how that plays out yet. But we do see that as we focus on the functional things, that catastrophization does decrease. And disability, some things show that it may start to be reducing, but we don't have enough data on that yet. Remember, the exposure is only increased in grade when fear has reduced. These are references I used to develop this. There's no published literature has graded exposure that outlines in a way that most physical therapists can replicate with simple screening criteria and commonly available resources. Thus, the model I used for this case really took from a combination of the resources you see here.